audience. I am presenting here our small study of clinical characteristic red blood cell indices, iron profile, and prognosis of heart failure in Indian female. The background being heart failure as we all know, is a leading cause of morbidity and mortality worldwide, with prevalence in India around 1.2 per thousand of population. Though it affects equally, heart failure affects equally both the genders, but females at older age are relatively at higher risk, and anemia and iron deficiency is relatively more common in females, as even in WHO paper, this is the most widespread and the common cause of iron deficiency. When we talk about iron deficiency and heart failure, this paper published in European Heart Journal clearly signifies clearly delineates how the iron deficiency is associated with poor outcome, especially in patients with systolic heart failure, as in this patient. The prevalence of iron deficiency is around 50% in Europe in patients of chronic heart failure, whereas in multi-ethnic Asian population, it was 61% in a study. If we come to India, the total prevalence of iron of anemia per se is 53%. So that puts Indian population at very high risk. The iron, which is primary the driver of all the organs, is affected significantly by the deficiency. Significantly leads to affecting outcome in heart failure. The heart failure, which can lead to iron deficiency by affecting various organs, whether it is renal or directly inflammatory suppression, or through angiotensin or fluid retention, or maybe simply because of anorexia. The iron deficiency, we can divide into whether it is absolute, where the pool is decreased, or it is functional, where the pool is normal but the utility is impaired because of the inflammatory milieu in patients of heart failure. If the heart failure in India is a huge unmet public health problem, which occurs in a younger age of a younger population, and so the data with Indian females is such limited. So we aim to study the heart failure in Indian females, looking for the clinical correlates, etiological profile, iron deficiency, and the prognosis in our setting in this institution-based study. We enrolled 147 females during the study period from September to 17 to March 20, which was all-comer study with females more than 18 years presenting with NYHA function class 2 to 4 were included in the study. We took the demographic details, clinical characteristic, red blood cell indices, iron studies in the registry which was maintained for the same. The other relevant investigations were performed. The standard heart failure definitions as published in JAC were followed for the comorbidity, defining comorbidities. Anemia was taken as less than 12 milligram per deciliter as per the WHO definition. The absolute iron deficiency and functional iron deficiency was defined as per the European guidelines of heart failure as taken from the ferric heart failure trial first. The exclusion criteria was acute coronary syndrome presenting with heart failure, or patients with other comorbidities like advanced chronic kidney disease, stage 4 and 5, chronic lung disease, chronic liver diseases, patients with malignancies, or who have received blood or iron transfusion within last 3 months, or who had other causes of anemia, or the patient had pregnancy. The patient were followed up in physical OPD as well as by telemedicine in view of COVID outbreak recently. Discussing the results of the study in the as we are landing from the pre-transitional to transitional phase, we divided the heart failure patients into rheumatic and non-rheumatic group, where still the non-rheumatic group was higher with 55% of the population. There was significant difference in the population characteristics of with higher age in patients with non-rheumatic causes, which included ischemic heart disease, heart failure with preserved ejection fraction, peripartum cardiomyopathy, etc. The renal failure, diabetes, hypertension, as expected, were higher in non-rheumatic etiology, with more people landing up in NYHA class 4. Atrial fibrillation was more common in patients with rheumatic heart disease, and beta blocker usage was more common in such patients with more compliance. Ejection fraction was significantly lower in patients with non-rheumatic etiology. When we come to anemia profile and iron deficiency profile, iron deficiency, anemia and iron deficiency, it was similar in both the groups, whether it was rheumatic or non-rheumatic, with anemia constituting 49% of the total population and iron deficiency constituting 89%, with 80% absolute iron deficiency and 9% functional iron deficiency. Then we try to look for whether we can correlate with whether, because iron profile is costly in rural setting, we try to look for red cell indices, whether we can clinically differentiate between patients with anemia only or patients who have iron deficiency only, rather than patients who have both iron deficiency and anemia. Or but there was no significant difference except in patients, if we look at the lower 5 columns of MCV, MCH, MCHC, there was no significant difference between all the groups except in when there was both iron deficiency and anemia, the MCV was reduced, which is expected out of iron deficiency, whereas other parameters throughout were similar. In follow-up data, the mortality rate was similar in both the groups, whether rheumatic or non-rheumatic, with similar rehospitalization, and there's no significant difference either in the mean survival time. When the Kaplan-Meier survival curves were plotted, there was no significant difference in survival of the rheumatic and non-rheumatic patients with heart failure. The composite of death and rehospitalization was also evaluated, and there was no significant still in patients with non-rheumatic or patients who were having rheumatic cause of heart failure. However, in patients with iron deficiency profile, it was the mortality was there was significant difference whether it was absolute or functional iron deficiency. The mortality was higher with borderline p-value of 0.045. Compared to other previous studies, like in Tremendum heart failure registry, which has higher prevalence of ischemic heart disease, our study still showed the population had a little pre-transitional diseases which were more common. The burden of rheumatic heart disease was higher in our population, and more population landed up in severe severe heart failure symptoms in Trivandrum degree of function class was there, probably because of higher contribution of rheumatic heart disease which were on our follow-ups. The comorbidities were significantly higher in patients in their registry because of more contribution of ischemic heart disease. And
can you come to your last slide, please?
Yes, sir. And compared to other trials, we can other studies, the prevalence of anemia was higher. The conclusion was the non-rheumatic heart failure is increasing as the society is going from pre-transition to transition phase. Iron deficiency is highly prevalent regardless of etiology, and iron deficiency definitely is associated with poor prognosis, and more contributing factors may be playing some role with diet and genetics coming into play. And the future direction we see as the intravenous iron replacement in Indian heart failure patients can definitely improve outcome, especially in females where the iron deficiency is so rampant. Thank you.
So, evening. So nice presentation. My question is that you're looking at females with iron deficiency. So did you divide them into pre-menopausal and post-menopausal, and was there a difference in the iron deficiency in the two groups?
So we didn't divide into pre-menopausal and post-menopausal. We primarily divided them into rheumatic and non-rheumatic. That could be one factor which will, but the iron deficiency was so rampant that it was to the tune of 90%. So the difference was probably not that would not have been so significant. So we didn't do that actually, because 90% is too high in total population.
Dr. Venugopal, you are muted.
Yeah. You said there is a significantly higher mortality in patients with iron deficiency. What are the causes?
Sir, iron deficiency per se leading to high mortality. There are papers with iron deficiency primarily lead to a multifactorial effect on like it is, if we primarily because of iron deficiency, it produces the state of once the functional status of the different tissues is altered, as it is involved in mitochondrial and oxidative functions. Then the iron is one of the antioxidant. It is the free radical injury is increased in patients who are having iron deficiency. Even
Okay,
the
that's fine.
anemia.
Okay. See, basically your groups are rather less having heart failure, less severe heart failure compared to the other study groups that you have compared with. Okay.
Yes.
I have just one question. It is now known that heart failure itself will impact iron metabolism. So, do you have from your studies any clue to that?
Sir, iron deficiency was if heart failure leading to iron deficiency is well-known fact. In our study, we simply profiled for the iron deficiency. We didn't actually look for any cause, but it was probably because the anemia and iron deficiency is so rampant in Indian rural setting that and increased intake of coffee, tea, sorry, not coffee, exactly, black tea and vegetarianism is one factor which may be contributing more to, and nutrition which is contributing more to iron deficiency profile in Indian population rather than functional deficiency, which is more of a function of because of inflammatory state leading to suppression of erythropoietin or hepcidin mediated pathways.
Okay, thank you.
Shall we go to the next presentation, Prachi Sharma?
Yes, sir.